the BLS crew tells you that they have not had any shockable rhythms. And so they're telling you it's asystole, but you look and you see that the patient does have, like, we'll say a heart rate of like 25, 30. So they're doing CPR currently. They stop the CPR for the rhythm check, and you see just like a couple little solitary beats going through. You have your ultrasound probe. We'll say you're subxiphoid right now, and you look and you see that the heart's actually beating. And they say, all right, 10 seconds is up, or 5-10 seconds. Let's start CPR again. So they start CPR again, get the Lucas going. And you could see that the patient did have contractions of the heart, but nobody felt a pulse during those. What are you saying to the crew to say, hey, we should stop CPR and try pacing this? Or what's your next step in that?
Yeah, I think if I'm seeing that, the first thing that comes to mind is, make sure you push the other stuff, the bicarb, the calcium, the other stuff like that, because now we are wondering, is this a metabolic issue, like you were saying, is it hyperkalemia? That'd be my first thought of seeing that rhythm. Um, Pacing doesn't jump out at me immediately just because I've done it less often. But honestly, after speaking with you and after kind of trialing that a few shifts ago, it makes a lot of sense to try that. I'm not sure that I'm turning off the Lucas while I'm doing that. My thought is, again, I'm focusing on perfusion. Maybe we're intubated, maybe we're bagging, whatever it is, we're checking end titles. And if I'm at an appropriate spot with the Lucas, like that's my first go-to. Get to where we need to get. Because it's pacing, right? With the Lucas, I've got that heart rate already. And then at that point, I would say, all right, man, that's pretty weird. Like at every single pulse check, we got a few of these good beats. Great. Let's start cranking up the pacing. We pushed our other meds. Let's start cranking up the pacing. And I would say I'm doing that with the Lucas on board, and then pausing. Maybe not waiting a full 2 minutes if I really think there's something good there. But pausing it and seeing, do we have capture? What's going on with this? If not, turn it all the way up, keep going, turn the Lucas right back on, let it pause for a minute or two, and see where we're at. And see if those meds have had time to work too at that point. And if that's what I'm seeing, I'm probably yelling for someone to come, if, maybe me, maybe a resident, whoever it is, to get a blood gas, because at that point, this is something pretty salvageable potentially. And I really want to make sure I'm not missing a pretty simple, electrolyte issue. But I probably got the Lucas on board, and yeah, let's crank up the milliamps. Let's see if we can capture, and let's pause that Lucas to see where we get.
Yeah, that's really interesting to me. I love what you said about the end tidal CO2 earlier, because that's important. Because if your end tidal looks like garbage and you're looking at the heart and you're like, oh, that looks like it should be contracting appropriately. I mean, albeit you could have some VQ mismatch within the lungs that's causing, let's just say they had aspirated or whatever. And so you're not getting a true end tidal CO2 value. But all things being equal, I think the positive predictive value of seeing that and saying that this patient has good perfusion is probably pretty high. And if you are pacing at the same time that you're doing chest compressions, what would you say the benefit of pacing is at that point?
I'd say there isn't much benefit at all during that point, but I'd say I would want to get that going already so that when I pause, that's not when I'm cranking up the milliamps. What I want to do is when I pause the Lucas, because I'm trying to minimize the amount of time that we're not perfusing. So if we got where we need with the Lucas, or with hands-on CPR, I don't work for them, not yet. But if we've gotten where we need with that, if we have, then I'm a little loath to stop doing the thing that's gotten us to where we want to be. And so that's why I kind of start those other processes while we have that. And then I'm pausing the CPR and pausing the mechanical device and seeing where we are with that. But the role of them in conjunction would be, I don't really want to wait and see if it works. I want to keep going with the thing that's working. When I'm pausing it, we're already on, high amounts of milliamps. Hopefully we're capturing. We take our 5, 10, maybe 20 seconds at that point to really try to figure it out. But otherwise, because the next step from our perspective is getting a transvenous pacemaker floated in if that's what it is, and that's tough to do with the Lucas ongoing, but it's not impossible. And so if you're getting what you need with that, then I'm favoring that over anything else. But I think the pacing ought to get started before, turn it off and see where we get. Especially if it certainly adds a risk of R on T and maybe devolving into something else, and certainly there might be some patients harmed by that. But typically, my mantra is if we're getting where we need with this mechanical compression, great. Let's get the hell out of there. Let's get to the ICU. Let's get to where I can get my monitoring. Let's get an A line in. Let's get all that stuff going. Because I'll take the downside of prolonged CPR to the downside of even a minute of less perfusion than what I could have gotten with it.
In those studies where they looked at pacing asystole, they did that exact same thing. They had chest compressions going while they were pacing. Makes sense, because it makes sense because of what you just said. When I first read it, I was like, I don't understand the benefit of pacing, trying to make the heart contract if you're actually manually pumping it. And when you look at some of the neonatal literature that looks at asynchronous chest compressions, when you have a native heartbeat but it's less than 60, and so you start providing artificial chest, or not artificial chest compression, but artificial beats with chest compressions on top of that, the coronary perfusion pressure actually goes down, because when you have a low pressure within that aorta and you push on the heart, you can have retrograde coronary flow out of the coronary arteries and actually steal blood from the coronary. So I was wondering, you got a patient that's got a heart rate of 20, 30 or whatever, and maybe that you don't feel a pulse, but you're seeing decent contractions. At that point, if doing those chest compressions could create that same situation, because we know our diastolic's low, and the diastolic pressure is what's feeding those coronary arteries. And so if you have a low diastolic pressure, you're pushing on the heart. Are you ever going to build up enough of a coronary perfusion pressure in that milieu? And I don't know. I don't know what the answer to
Yeah,
that
no,
is.
you're absolutely right. I don't think you would. But then on the other hand, if your issue is not enough, coronary perfusion pressure, I'm wondering if your presentation is going to be this sort of hypersymptomatic bradycardia at that point. It certainly could be, right? I mean, why not? Like a focal ischemia could certainly give you a heart block or this kind of a profound bradycardia with pulselessness, at least palpation by fingertip. So it could be, but I think at the point where we don't know, I think I'm probably erring on the side of using the Lucas device or whatever, continuing with CPR, turning on the pacer, and then holding. I mean, you're definitely right. It might, in fact, work against you, but then again, you're pausing after 2 minutes, and if you are seeing capture there, if you are seeing good rhythm, great. I think you've stopped. But you bring up a very good point that I'm trying to have my cake and eat it too, and that gets to how hard it is to be finesse, to be with ACLS or with cardiac arrest care. It's hard to do that, and so it really takes a lot of thoughtfulness and a lot of really second by second thinking and managing and watching what you're seeing on the ultrasound as you're pausing your Lucas or asking for hands off the chest, because it's you could definitely see the downside to that.
Oh God, yeah, absolutely.
But hopefully after just a few minutes, you might see the pacing actually kicking in. So
And I'm trying to relate this to neonatal literature, but there's some nuances to that, and like most of these cases, the patient has a patent ductus arteriosus, which could cause you to have a harder time getting your pressures back, your or increasing systemic vascular resistance. And usually, if you're doing chest compressions, you're doing things like epi as well, and you are shuttling blood from the right side to the left side, hopefully at a fast enough rate, or I should say fast enough, but at a good enough rate that you start to rebuild that diastolic pressure. And the epi on top of that, I don't know if you would still have that issue, but it was just something that popped in my head when you were saying it. But that's probably, I don't know how well that extrapolates over to adults. I do a talk called Compressions on a Beating Heart, and
yeah,
we look at the literature on doing chest compressions on neonates, and essentially like there's no good evidence that that's a good idea. Like, obviously, if their heart rate's 10, that then it makes sense to do it. But like in the patient that goes from like, you know, they're born, they have respiratory distress, and the heart rate goes to like 60, and we start doing chest compressions, that can actually compete with ventilation, which is probably what the kid needs in the first place, is ventilation. And so it was interesting because of the pig data, you could see that they had retrograde coronary flow with those chest compressions. But I don't know. I would say that you'd have to have some profound vasoplegia, because most people, by the time I get there, are given a truckload of epi. And so that
Yeah.
systemic vascular resistance is probably high enough to prevent that retrograde coronary flow.
And you bring up a point too about like, okay, if we're trying to maximize coronary perfusion pressure, then that means that we're trying to maximize our chances of restarting spontaneous circulation, right? But on the other hand, and plenty of times, in my critical care patients, what the heart wants is not what the rest of the body wants. And acute ischemia MI with cardiogenic shock, dobutamine. Yeah, it's going to make the heart beat a little stronger. That'll probably help the kidneys. It'll help the brain. It's going to worsen oxygen demand. It's going to hurt the heart.
Mm-hmm.
So it really gets into kind of like, what are our goals in cardiac arrest care? And I think we focus a lot on this coronary perfusion pressure, and we focus a lot on cerebral perfusion too, of course, and that's probably the real money point there. But plenty of times, if we're favoring better coronary perfusion, we're not going to, the cost of that is going to be worsened forward flow. And so it makes you wonder, if it's someone viable enough that could get to ECMO, that could go to PCI, that could get an Impella, that's an overdose. It's going to get better in a few days, potentially. Maybe they can get through with mechanical assist devices favoring the end organs at the expense of the heart at that point. We're not trying to get the heart restarted. We're trying to maintain adequate perfusion to the rest of the body, including the heart, of course. But sometimes those goals might be in competition, and so I think it really is less about getting back to return of circulation. We feel a pulse, great, yeah, high five. But that's not really that relevant. The relevant thing is, how's the brain perfusing? How's the rest of the body perfusing? Because you don't need a heartbeat to have a perfusion. You don't need a heartbeat to be alive, right? Not anymore. Not in 2021. So it adds a lot of layers to like, what are our goals here, and what are we actually trying to achieve? And I've got to say that, when I'm doing this, I'm not that interested in necessarily getting back to native function. I'm more interested in making sure that there's some degree of baseline cardiac output that's getting to the rest of the body, and favoring that over anything else at that point. And that's why, I'm pretty comfortable just leaving the Lucas on, not even checking a pulse, and just whisking them off to the ICU at that point. We are where we need to be. We've got the perfusion pressure. We've got the end tidal. Maybe we have an A line in that's shown us a good pulse, a good pressure. Great. We're in business. And then we can call cards. Then we can start putting stuff in the groin. Then we can think about going on extracorporeal support. But the heart is a lot less sensitive than the brain to this kind of ischemia. And so often, so often we get these terrible cases where, great, we got the heart back and we dialyzed through the kidney injury, and now the kidneys are working, everything's working great, except that the patient's brain is cooked and they're never going to move again. And so we've gotten to a point where we're much better at protecting and at supporting and at like supplementing and replacing all the other organs, but not the brain.